Welcome to this third PCR webinar on bifurcation lesions. The title of our webinar is Step-by-Step Planning and Performing Bifurcation PCI Requiring 2 Stents Upfront. My name is Goran Stankovic, coming from Belgrade, Serbia, and with me in the PCR studio are Tom Johnson from Bristol, UK, and Maciej Lesiak from Poznan, Poland. So there are following objectives for our today's webinar. First one, to understand which bifurcation lesions may require 2 stents upfront. Then to obtain tips and tricks on the planning and treatment of true bifurcations with 2-stent technique, planning, pre-procedural aspects, treating, procedural tools and technique. And finally, to consider strategies to prevent and manage procedural complications. So we are discussing today upfront 2-stent strategies. We moderated and participated in many events like this one, and one of the most frequently asked questions is when 2 stents upfront are needed. Any comments, Tom?
Yeah, so it's very exciting to be here this afternoon, and I think we're shifting up now from provisional stenting to complex intervention, and this is complex bifurcation disease that we're going to look at as a case example. And we have to acknowledge that although we're driven very much by guidelines, by consensus, that actually the complexity of our patients, and more importantly the complexity of their disease, is increasing constantly. And so today, really the emphasis is on gaining strategies, understanding how we can plan and effectively give our patients the best possible outcomes in complex intervention.
Yeah, thank you, Tom. Maciej, anything to add?
Yeah, I think that it's going to be really a great session because, as Tom mentioned, there are more and more patients with complex disease. And I think that one of the messages should be that using 2 stents with current generation thin strut stent is really very good for our patients. There should be no special penalty of using 2 stents. So I think that we should persuade people that if you really need to use 2 stents because of the patient and lesion complexity, you should do it very freely because you may expect very good short-term as well as a long-term result.
Yeah, to discuss that, we selected a case. So, Tom, you selected one of your recent cases. Can you please lead us through the case?
For sure. So this is increasingly a typical scenario in Bristol, I'm sure elsewhere in Europe. So a 77-year-old gentleman who presented to us independent, but I think we acknowledge quite frail, in the setting of a non-ST elevation myocardial infarction. So he has a troponin rise with some lateral T-wave changes, and a pre-angiographic echo shows for us moderate left ventricular impairment. Risk factors: hypercholesterolemic, previous smoker, hypertensive, and really the only worthwhile past medical history is pernicious anemia, but with a hemoglobin of 90 grams per deciliter. So he comes to our cath lab, and here we have images of the right and left coronary systems. We have evidence here then of a kind of codominant system with actually some backfilling from the distal right coronary to the circumflex territory. And on the left shots, really very complex distal left main, but predominantly proximal LAD, proximal circumflex disease. So we see some backfilling there into the circumflex territory. And here in this PA caudal view, we see evidence of really very clear-cut severe disease at the ostium into the proximal LAD, and additional disease with sort of TIMI2 flow in the circumflex. And importantly, if we then come down to this spider projection, we have both the evidence of very high-grade disease, but superimposed upon that very significant bulk of calcification. Now, it's not my normal practice, but actually, if you look at both the anatomical and clinical syntax scores, interestingly, because the disease is limited to the left main, we have a syntax which is only in the kind of on the border of the low to middle tercile, although I'd have to say this is complex in terms of intervention. But gratifyingly, when we then look at the comparison between surgery and PCI by syntax 2, we have relative equipoise, slightly higher risk by PCI than by bypass surgery. So complex distal left main proximal LAD circumflex disease.
Yeah, definitely very complex anatomy, codominant circ, but it's acute coronary syndrome. Maciej, any considerations about that?
Yeah, this is, I think, really a great example of a patient we can now find in our cath lab with the ACS. What Tom mentioned is this complexity is growing, the number of patients is really growing, and I think that's after discussing whether this patient should be considered for surgery or just discussed on a heart team with cardiac surgeons. Otherwise, I think that this is a great case when we can think that 2 stents upfront technique should be very useful given the anatomy of this lesion, given the involvement of 2 large branches. The circ is the biggest side branch that we have in our hearts. And given a bunch of calcium, what you see on the image, I think that 2-stent strategy will be necessary with this patient.
Tom, what were your considerations when you looked these angios? You had heart team, I guess. What was the discussion and what you decided?
So I think Maciej has nicely summarized really the kind of considerations in terms of provisional versus 2 stent, and clearly this being left main and in a very sizable circumflex side branch, we have significant jeopardy. And again, 2 stents was absolutely appropriate. Now, although this was in the setting of an acute coronary syndrome, and although having looked at the scores we see a relative equipoise, I have to say it was our practice to stop and to discuss both with the patient and also with our surgeons about whether bypass versus intervention was appropriate. And I think unless it was in true extremis, unless the patient was hemodynamically compromised, there was ongoing
this
ischemia.
This was non-ST elevation acute coronary syndrome, so this leaves you some time to properly analyze and discuss.
So this gave us flexibility to think and to discuss best options.
Yeah, so large circ, codominant, diffuse disease, a lot of calcium, even angiographically, a large area of myocardium at risk, and definitely it's 1-1-1. I don't think there is doubt about that. One of those scary complex anatomies where you don't want to lose any of the branches. So if we decide 2-stent strategy up front in order to preserve both branches and to preserve a large myocardial area at risk, there are several different valid options. T-stent, TAP, TN protrusion, culotte, DK crush, V-stent, modified V-stent, or even in some centers SKS or shotgun. So, Maciej, when you see this anatomy, is there anything that you would use as a recommended upfront 2-stent strategy in your experience?
Yeah, we just nicely presented a couple of options we can use of 2-stent strategy. I'm the user of DK crush in many cases, and I think this particular case is very suitable for this technique, and let me tell you why. First thing is I feel very comfortable dealing with very complex lesion with 2 branches, very sizable branches, circumflex and LAD, to keep the branches safely throughout the procedures. And this technique gives me this, ensures that I will have the 2 branches open for the whole procedure. So that's one point. The other point is that we can obtain very good angiographic result with a very nice long-term results as well, because now we have more and more data on this technique published for many years up to now, dedicated to non-left main as well as left main, comparing to provisional and comparing to culotte stenting. So I think that although it's a little bit demanding technique, after some experience, I would recommend DK crush in this particular case.
Another valid option, at least in my hands, in my experience, is culotte. Similar vessel size in both branches, circ and LAD. Favorable, large proximal left main to open and deploy adequately both stents. Another option that is also feasible when I look this angle, and if I consider circ as a target lesion in this case, is maybe inverted provisional T stenting from left main into the circ and then do TAP, a second stent towards the LAD. In that case, you consider LAD as side branch and circ as the main vessel. So many different options. Tom, what have you decided? What was your strategy?
So, I mean, the thoughts are very valid. I have to say that in this situation with this patient, my feeling was to try and simplify as much as possible the bifurcation. And so the preference was a TM protrusion approach, as Goran has just outlined, in terms of stenting left main circumflex, large vessel, and then side branch of LAD. Now, I have to say my greatest concern was probably the calcification, and so went with a femoral approach, although I'm a 80-90% radial operator, purposefully went 8 French to facilitate then rotablation, debulking of the calcium up front. And I have a tendency to use imaging, and in this case, due to the ostial left main large vessel, selected IVUS as my imaging strategy.
I think excellent case, and already got a lot of attention from our participants. So you partially answered, but question is very concerned of calcific fibrotic polygon of confluence area. Yeah. It seems preparation of this area quite often was overlooked and ended up with unexpanded stent at this side. Tom, can you comment on that one?
I agree wholeheartedly. So I think the concern, and it's an evolution of practice, I think, that now that we use imaging more, and now that we have strategies, not just rotablation, but other devices for treating the calcification, we have to be looking more closely at the polygon of confluence, at the ostia of both side branches, because that's where we see failure. And so hopefully this case will give us really some nice kind of support in that message, I think.
Yeah, and 2 questions specific on strategy. We discussed DK crush, TAP, TAP, culotte. In true left main bifurcations, we have robust data on 2 stent strategies to be adopted. Do we need to consider all strategies like SKS, which have proven poor long-term results? Maciej, SKS in your practice?
I'm not a fan of SKS. Actually, I never use this technique. I know there is some papers on that. I think the only use of this technique is when you want to be really very quick. You use large guide like 7 or 8 French guide, and then you can go together with 2 stents simultaneously and fix the lesion and patient problem within seconds. Yeah? So that's the only reason. But then you may encounter a lot of complications, not only short term but also long term. You know all the story about neocarina, very funny pattern of restenosis, etc., etc.
One
so
of the main limitations is that during inflation you have twisting of 2 stents, and you have always asymmetrical expansion. So always one is penalized, and you have half a moon shape of one stent, usually the smaller one. Why not V-stenting? That's the next question. So you don't have double barrel long metallic neocarina, but you just focus to 2 ostia. Tom, V-stenting, is it option?
I'm going to show you very shortly why that might not be an option. I think looking at this picture we have now on the screen, you could argue that's a valid approach. Yeah. But I think what we're underestimating is the extent of the disease extending back into the left main stem. And so the V-stent is one. There's the extended V, or the Helkvist, which would be to stent the left main so you protect the proximal main vessel and then deploy your Vs. And that, for me, really is probably a safer approach than V if that were the way that you're passing. But there are clearly lots of options, and there are pros and cons for every strategy.
Yeah. 2 comments while we are still at this baseline angio on thrombus presence. It looks like there is large amount of thrombus across the ostium of the circ. And second question, we may have quite a good thrombus burden. Wouldn't it be wiser to do V technique so as to have less balloon inflation in order to avoid non-reflow phenomenon?
So maybe let me show you the next image.
Yeah, so maybe we go to the next image.
So again, an absolutely spot-on comment, and the fact that there may be thrombus. Are we misinterpreting the haziness as thrombus or calcification or a combination of the 2? Well, here we are, 8 French from the leg, and 5 days later, so having had the discussion, having met with the surgeons, we actually find that this patient's closed their circumflex.
So anatomy has changed, actually.
So the anatomy has evolved.
Yeah.
negatively, it would have to be said.
So you have to reconsider your strategy. Maciej, what would you do now?
Yeah, of course, now the situation has changed. We can discuss whether it was worth, waiting those 5 days, but I think that's another story. So definitely we should try to open the vessel, but what one of the participants asked, and also what Tom has mentioned, I would love to see the IVUS of this lesion, because we can very easily mix up the calcium with thrombus. And now, since we have ACS patients and the vessel is closed, so perhaps that's more thrombus than calcium. Of course, we see a lot of calcium on angiography as well. So I think the IVUS will be great tool to after reopening at least try to open a reopening of the circuit.
Yeah. Okay. Tom, I guess you did IVUS. You said IVUS guidance must.
Yeah, I feel like I'm opening Pandora's box. So here we are. So we'll skip over the sweat and tears that were involved in the Fielder XT, Corsair, exchange, pre-dilatation of the Circumflex.
Almost CTO-like case. Yeah.
We get back to where we were 5 days before, and I think Maciej is absolutely right that before we go any further, we need to understand what we're dealing with. And so for me here, this is where the role of imaging is absolutely clear-cut, because it's all very well, we've made an interpretation of the angiogram, but until we look at the IVUS, we're not really certain. Is it calcium? Is there thrombus? How big is the vessel? Where does the disease burden sit? So this is the first run from the circumflex back to the left main, and we see that we have a reference distally of 3.5 millimeters in the proximal circumflex. We have a reference in the proximal left main in the order of 4.5, 5 millimeters. And then as we pull back from the circumflex, we see a very, very high burden of calcification and a very large left main. So it's not fully circumferential. We see that there's an area from 4 up to 9 o'clock of relatively healthy looking vessel, but there's at least 180 degrees of calcification, and it significantly invades the luminal space. I have to say we don't see much thrombus, but I've been ballooning, and I'm sure there was thrombus in view of the acute nature. But certainly this informs us that we've got very high-grade disease.
Yeah, and next image will show us again angio after IVUS. So, Maciej, where we are now?
Yeah, what I see now, the vessel is open, so now we know that what we see, this haziness, it's not a thrombus, but it's mainly a calcium. So I'm really satisfied with this guide, 7 or 8 French, even 8 French, because now I know, just having seen this awful calcium in the circ, that I will have to use a rotation atherectomy, and it may be that I will have to use a burr bigger than 1.5 or 175. So, of course, it is doable with a 6 French catheter radial approach, but given the size of the vessels, left main and large, almost dominant circ, we may expect that the larger burr will be needed. So I can only congratulate that you upfront chose the big guiding catheter, but it's really important in this case.
We have a tendency of various levels of expertise, and there is a very nice question. Could you simplify what technique we, non-expert practitioners, could use in more than 90% of such complex bifurcation? Can we do it?
So my recommendation to not very experienced operators will be use the complex technique, the one you know the best, because then it can be done with culotte, it can be done with TO tap, it can be done with DK crush. So do your best with the best known and technique which you feel most comfortable. Then of course if you go a higher level, then but anyway, I practice in most of that cases DK crush, and I feel I'm best in DK crush, which does not mean that I cannot do culotte, but I'm not that expert in culotte, since I do, in most of my time, I do DK crush.
You do DK crush, yeah. One question before we switch to your strategy. Should have cardiac MRI before opening LCX? It's just 5 days.
So it's a good question in terms of viability. Is there a need for us to open the circumflex? The echocardiogram was fairly compelling for the fact that there was remaining viability in the circumflex territory. The patient hadn't changed in terms of their status in that time, but it's a valid comment.
So you decided to proceed after this IVUS. Have you changed the strategy? You remained with TAP? Or?
Yeah, so a couple of comments. I think in terms of the learning and starting, then actually there shouldn't be any fear of asking a colleague to join you, and having someone with you and actually sharing the experience and having someone that can also assist you in the decision making and take some of the heat off the pressure of what can be a challenging procedure, I think is really valuable. And these are cases that if you can run by dual operator is a luxury, but one that's very useful. So absolutely my strategy did change, and you can see that there's kind of an evolution of decision making. I became increasingly fearful of losing those branches. And so Maciej has already highlighted the benefit of DK crush in protecting your branches. I have to say I shifted at this point to undertaking this as a DK strategy.
Yeah. So the main difference is actually whether you start by stenting side branch or main branch first, which one you want to preserve.
Yeah.
Can you lead us, as probably one of the most experienced in DK crush, through the steps of the DK crush, so you help both of us and also our audience to follow later the steps of the procedure?
Yeah, so this is a well-known technique published in many papers now. So we start with the side branch, and with this particular, so this is a kind of side branch first procedure, and going to semantics, in this case we can pick the Circumflex as a main vessel and LAD as a side branch, because the Circ is really a sizable vessel, codominant perhaps to RCA. So depending on which we judge as a main vessel, we start with. So we start with the side branch with the implantation of a drug-eluting stent with some protrusion into the main vessel, as you can see here, after, of course, the proper preparing of lesion predilatation or rotation atherectomy, as probably in this case. We size, of course, the stents according to the reference of the side branch, with some protrusion into the main vessel. Now it's a very important point, and you should not forget about this, that before crushing the stent, you have to remove your wire and the balloon. And during the implantation of the side branch stent, you should keep your balloon deflated in the main vessel in order to crush the stent, and otherwise you may have really problems with delivering the balloon for crushing to the main vessel. So as you can see on this image, you have now implanted stent into the side branch, and you are just about to open the main vessel stent after removing both balloon and wire from the side branch. So this is what you do. You open the balloon, and I can only also recommend in this stage that sometimes it's very useful to use slightly larger balloon, even do a kind of post-dilation. I don't want to call it POT because it's not POT, but it's very important to crush the stent properly, not to leave the crush stent partially open. Yeah, because otherwise you can wire partially interluminally, and then you may have issues with further procedures. So you crush the stent, and after that you rewire and perform the first kissing. So with this first kissing, you obtain a very good inflow, very good opening of the side branch. So you kiss for the first time, and you get rid of the 2 layers of a stent. With the regular crush, you have to cope with 3 layers of stents after implantation of main vessel stent. Here you are just getting rid of 2 layers of the stent, so it will be easier to rewire afterwards. So now what you do, you remove your wire and balloon from the side branch again, and you are ready to stent the main vessel.
Yeah, if I can interrupt just for a second, for the audience. I spoke with Professor Chen, who invented this technique, and I said, why don't you simply just inflate balloon inside the stent without main vessel? Because I was personally afraid if you do kissing in a non-stented main vessel, you are oversized and there is a risk to dissect proximally. And he said, I'm doing it on purpose, because if you do kissing, you actually don't allow metal to protrude inside the main vessel. So that's the main rationale behind the first kissing. Please continue,
Yeah, you
Maciej,
correct
and
the
sorry
position of
for-
the carina as well, yeah. So now you're ready to deploy our main vessel stent, and of course the length of a stent should be as needed as for the lesion, but the diameter of the stent should be taken regarding the distal reference. So you should size your stent also as with provisional stenting according to distal reference. So you see that's the implantation of the stent in the main vessel, and what you see now is a gap between the crash stent and the main vessel stent, which means that you have to post-dilate before you rewire again. Otherwise, you may gut your wire in between the struts of the main vessel stent and the crash struts of the side branch stent. And this is very nicely presented on this picture. You see how nicely we push the metallic struts of the main vessel stents towards the ostium of the side branch, and now you can safely rewire, knowing that you'll get into the lumen of the main vessel stent. Perhaps I forgot to mention one also very important thing, that contrary to provisional culotte tap technique, you should aim to rewire not at the most distal strut, but instead you should point your wire somewhere in the middle of a stent or proximally. Because if you rewire in your distal strut, you may get your wire a little bit under the first few struts in the side branch stent, and then after kissing you will increase this gap. So going back to the procedure, you rewire again. What you see now, 2 balloons sized for the according to distal reference. You may go high pressure. It's very desirable to use non-compliant, short non-compliant balloons, of course, without any protrusion outside the stent. And I think it's also good to finalize with another POT, with another pot, with adequately sized NC balloon in the main vessel.
Yeah, thanks. I think it was really excellent. We have a couple of technical questions. Using 8 French size, do we take into consideration side holes catheter? Nope.
I wouldn't be looking to use side holes simply because I think it gives you a false reassurance. So you're not often sure about the nature of the patient's pressure and hemodynamic status.
Okay, so
and,
no side
and
holes.
greater contrast volume.
Yeah, no side holes. Protrusion of the side branch into the main branch. What protrusion is considered appropriate? How much you protrude?
I think the less the better, yeah. So you don't have to cover the long stretch of it's a kind of mini decay crush, but of course the whole part of the stent had to protrude into the vessel to leave some space to do the kissing through the struts of the stent. Yeah?
Yeah, another question, do you backstop a balloon in the main vessel before placing side branch stent?
So Maciej has already highlighted that as a very important factor, that the risk of deploying the side branch stent without equipment down the main vessel risks you then not being able to get a main vessel balloon back down. So yes, you have a balloon trapped.
Okay, other questions we can answer throughout the case. So Tom, let's apply in your case all these steps, trying to comment and explain why you did something. We saw a lot of calcium, so lesion preparation is necessary. Is it possible to start such intervention by ballooning the lesion and perform rotablation in case of failure only?
Yeah, so clearly we have had to predilate this lesion already in view of the fact it was closed at the very beginning of the procedure. So we've palpated the lesion. But I think beyond that, as we've seen with the IVUS, we then have very clear evidence of a high burden of calcium.
Perhaps one word of caution of predilatation and rotation atherectomy. It's not really is not recommended because here was where the vessel was occluded, so there was no other choice. But otherwise, you may just create some dissections, which will increase the risk of complications. So, if having known the IVUS, I would go directly for rota. But of course, in this case, the vessel was closed, so you have to use balloon.
Yeah. So I guess just to recap, we've reopened the circumflex, we've IVUSed and we've shown high burden disease. My strategy's changed from TM protrusion to now to a DK crush, considering the circumflex actually is the larger vessel, so the main vessel. I was quite keen initially to get an understanding of the LAD disease as well before embarking on optimizing prior to stenting.
Yeah.
In fact, I couldn't get the IVUS catheter down the LAD. I did predilate the LAD, although as Maciej says, there is a concern that you might create dissection, you may complicate the strategy, but I ballooned just to be sure. And then actually went about debulking the circumflex. The 8 French, someone's already commented on why 8 French. Well, 8 French because up front I had this concern we were going to need to use a large
So
burr.
there is a question, is it possible to perform decay crush with 6 French guide through radial?
Yeah.
Most often 6 French guide don't admit 2-3 millimeter balloons.
So the majority of the Chinese data is on 6 French, so absolutely it's valid. The reason for 8 French
And
here
radial,
is the
how
calcium.
often do you do it radial? In this case, I think you already described why you selected femoral instead of...
Yeah, but in most of the cases, you can use radial, of course.
If it was not that calcific with such big vessels, probably radial is also a very valid option.
6 French catheter allows for 1.5, even 175 burr. Yeah? So you can use radial 6 French up to. But here we could expect that we will use bigger burr.
We see 2 millimeter balloon was used for better
which
preparation.
is impossible, with this size of catheter.
Tom, please lead us through the case.
So we can see heavy burden of calcium, that lower panel with the burr really almost stalling in the proximal lesion. But actually, we see some improvement of flow distally in the circumflex. So at that point then, actually I get to get an IVUS probe down the LAD, and you might say, well, that's surely overkill, but I want to be absolutely sure before deploying stents that I understand the architecture, the geometry of this bifurcation. So we see a large differential in size from distal LAD to left main 4 to 5, almost 6 millimeters in diameter. And as we pull back through the ostomy of the LAD, we see almost circumferential calcification. Yeah. And again, this causes me concern, and we've already had comment from our participants that this is the point at which this procedure may fail long term. This is where we may see restenosis.
You don't expand stent.
And so actually I took a view then to move to optimizing the LAD pre-stent then as well. So then rotablating into the LAD, so clearly having to remove equipment from the circumflex.
You had to remove, in that case, circumflex wire. Okay.
Absolutely right. And so there's a jeopardy there. Clearly there's a balance, but my concern actually is the long-term result at this point. And the patient has been remarkably stable through this. And this is where we're left, having taken only just the 1.5 burr down the LAD, but clearly with some resistance at the ostium. And actually to take it one step further in the preparation, taking then a cutting balloon in both the circumflex and the LAD limbs to ensure that we've adequately expanded the vessel. So really preparing this bifurcation as much as possible prior to the implantation of any stent. And this is where we're at post-debulking. Okay. So at that point then, we've already commented on the idea of considering the LAD as our side branch. So a protective balloon, as we've commented very importantly down the circumflex, palpating the circumflex. And here I have placed a 3.5 by 38 millimeter drug-eluting stent. In fact, slightly oversized for the distal vessel, but using a very nice technique shown by Francesco Bozzotta of just expanding the balloon very, very slowly to a subnominal pressure. So the 3.5 is the same as a 3.0 stent in this setting, and then pulling back and expanding further. And then obviously kissing and taking this 3.5 non-compliant balloon because it was already down there to kiss. But actually when we consider looking back at the IVUS, if that's our 3.5 stent sitting in the left main, then my 3.5 balloon actually hasn't achieved very much. So it's really important, although this isn't a true pot, but it's really important to come back with a larger balloon in such a large proximal main vessel to then further inflate and crush that first side branch stent truly into the wall or roof of the left main. And so hopefully by this step, a sequential incremental post-dilatation of that first side branch stent, we're then at a point where we can recross. So here we see very nicely the passage of the wire across the crushed ostium of the stent into the LAD, we believe the side branch, prior to then embarking on the next steps of the bifurcation.
But this is a crushed segment, and actually sometimes we can face difficulties and have failure. Maciej, a couple of advices for our audience in case you fail with workhorse wire?
It may be really sometimes difficult. One thing very important here is to crush a stent with adequately sized balloon. So if my regular wire doesn't go, then I'll take a bigger balloon and do the crushing again, or the pot in other techniques to overstretch the struts of the stents to make the cells bigger, and then in many cases it works. If not, I really do try to do my best with the regular wires like BMW or Sion Blue before I move to another step of stiffer or hydrophilic wires, because you may expect some problems. Just 1 week ago in provisional stenting, I lost the side branch, fortunately temporarily, so I managed to rescue the side branch. After failure of recrossing to the struts of the stent with a regular wire, I moved to hydrophilic wire, and it went really smoothly, but unfortunately created a dissection, an extended dissection down the vessels, and to my horror, I saw that large diagonal disappeared. Yeah? So you have to be very cautious with the stiffer wires. So I would say just regular wires, do your best effort, reshape the tip, enlarge the struts of the cell. If not, of course, then go to the polymeric plastic hydrophilic wires. I would go from filter, regular filter, not FC, through the whisper and pilot as a last resort, because going into more and more aggressive wire, you increase the risk of ostial dissection.
Yeah, few questions technical again, but I think part of that is already discussed. Do you keep the wire in the LAD during rotational atherectomy of the circ, and vice versa?
Nope.
I saw one case several years ago, and what happened is operator forgot to remove side branch wire, and at one point during rota I just saw shortening of that wire and then just disappearance. So never
to cut the wire. You can do this only if wires are not touching and one is in the LAD, and you do the distal circ. There's never.
But you know, with 8 French, if you use guide liner, you can do rota through guide liner as option. There is article in your intervention. And when we are discussing guide liner, is a guide liner may facilitate IVUS delivery into LAD before that dilatation?
So in fact, we haven't talked about guide catheter, and you may see that that's actually a Judkins guide. And I have to say that often in my practice for left main, I'll use a very passive guide for fear of engaging too heavily into the left main stem. And I think we're facilitating passage of equipment by the preparation, so by the rotablation. Actually, the guide catheter becomes less of an issue, I believe. But it's a good point. Increasing the guide support may help. Do you consider assistant device? I think maybe probably Impella or... This was a moderately impaired ventricle, and actually the patient tolerated this procedure very well.
Only if there is a really depressed LV function up front. So if you have a patient with ejection fraction like 15, 10, then you can consider. Never in this case.
Yeah, so we already answered. Is it possible to perform DK crush with 6 French guide through radial? Yes. Most often 6 French guide does not accept 2-3 millimeter balloons.
No, it's not true. You can go with with current balloons and good guiding catheter. You can go with 3.5 balloons together.
4035 makes difficulties. Below that, it's acceptable. So successful recrossing through a middle cell. Next step, please.
So we say successful. We're looking at the angiogram. We can't be absolutely sure, and I think you could re-image to check the passage, and there are some studies ongoing looking at wire cross. The fact is, I often use just one of my used balloons and see how it passes, and you'll know very quickly if you've gone under a proximal strut, because the next device won't pass, and you see very nicely here the balloon passing smoothly. And so from that point, then we come and we kiss, actually just with a semi-compliant balloon I've used here in the LAD, slightly undersized, 3.5 NC in the circ.
There was a question, it disappeared now, but what kind of balloons, what size, and what pressure in atmospheres you are using?
So I think for the kissing, certainly for the final kiss, and we'll highlight the importance of a final kiss, it's recommended that you use non-compliant balloons. You can see with a procedure like this, the equipment list has increased exponentially, and you have to be practical and you have to acknowledge cost. And so I'm using the balloons that are on the table, honestly. So I will take the next one. The issue about 6 French, you will find that maybe used balloons don't pass so easily, and so you have to think about taking new balloons. So people may find 6 French difficult just simply for that reason. So this is then placement of the main vessel stent, so from left main ostium into the proximal portion of the circumflex. And
after removing wire from the LAD.
Importantly, removing the wire from the LAD. And here then we see the result having deployed that stent.
And geographically really looks very nice. Maciej, are you happy? There is something missing?
We all know that angiography is misleading, and especially in this kind of procedures when we're dealing with a complex bifurcation of the left main. So I don't believe in angiography in that case. And the other thing I mentioned before, that we try to size the stent according to distal reference. So we know that there must be some malapposition in a main vessel, which is left main. So definitely, although the look is, angiographic look is great, we have to post-dilate with adequately sized balloon, like 4.5 or full wall balloon, otherwise we may get under the struts. We may rewire abdominally the stent and then create some mess of the wires in the vessel. So I strongly recommend to do the POT even without IVUS.
So next step, POT as mandatory step.
Yeah.
Tom?
We can discuss about the final POT in this complex technique.
But first POT after deployment.
But now, just to avoid, and which is especially important in the left main, because your guide is very easily pointing towards the gap between the stent and the, especially in the techniques when you have a jailed wire in the circumflex, your guide is always pointing to under the stent. Yeah? So do the POT and then rewire. Yeah?
And then people are frequently afraid, especially in calcified milieu. It's very dangerous to do POT.
If you keep in mind that the average size of left main in European guys is more than 5.5, then it's very difficult, almost impossible to really jail the wire and not be able to get it back. So don't be afraid about this.
I'm very happy to sit here and ask questions instead of answering these difficult questions. At every seminar there is a question, should we do POT before exchanging wires? Why don't we exchange and then do POT? I think you answered quite nicely that the main idea is first expand. Otherwise, you will never see if it goes in and out or completely behind the stent. You discover it lately at IVUS imaging, and then you see. POT was done, I guess, in this case, after deployment.
Yeah, so I mean, the jeopardy is clear. We've got a 4.0 stent in the circumflex. We've seen by IVUS that the left main is 5.5, as Maciej alluded to. So clearly the POT is important. And just to emphasize how we do that, so the critical issue here is placement of the balloon, and this is sometimes overlooked, and using your distal marker on the balloon and placing it onto the carina. Now the benefit here is we have the scaffold of the vessel stented to see the precise location of that balloon, but then it means then we can inflate and very clearly gain apposition of our stent into the proximal left main stem. And so you'll have noted I used a 4.5 balloon in that first kiss, which was not a POT for fear of causing that dissection, the concerns we had about injury. But here we've used the IVUS to adequately size, and this is now a 5.0 NC POT in the proximal left main.
Does the type of stent make difference in this or in any technique? There is a question, what kind of stent would you use for left main?
So you need to know your stents, and so clearly the different scaffolds expand to different levels. The different companies have a different number of scaffolds, so you find between 2 to 4 platforms according to the manufacturer. And so a 4.0 stent in the majority of manufacturers will go to 5.8, 5.9. Obviously Medtronic with Onyx have a stent that will expand to 6 millimeters in the largest stent. but you absolutely need to know the stent you're using and the capacity it has to expand.
Yeah, but as for this extra large stent, you have to keep in mind that according to any guidelines, you should size the stent according to distal reference. So if you take upfront that big stent, then it makes it very difficult to keep the carina.
So most of new generation stents will do drop.
So the best stent is you can really size according to distal reference like 3.5, and then you can go up to 5.5, for example. And you have to know whether your stent really expansion capacity of your stent is that big.
Yeah.
What do you advise to do if we have problem with balloon crossing in the side branch for kissing?
Yeah, there are lots of options.
Couple most frequently used.
Yeah, what I do, having two stents in the vessels, you can very easily and very safely perform an anchor technique. So you can park your balloon in the main vessel, open the balloon. You have 8 French catheter, but you can do also this with 6 French catheter. Inflate the balloon, make an anchor to your guide, and then you can very easily recross.
If distal stenting allows you to position balloon inside the stent.
But what I do firstly, I would expand the POT balloon. So I would go at least 0.5 millimeter bigger. Then you overstretch the struts, and very often that makes it easy. If not, you can exchange the wire again, rewire, try to pick a distal different cell than the previously.
Yeah. Next question, is the LAD ostium optimally dilated? But I think we come to that question now because after POT you are recrossing again.
Exactly. So the pot has nicely expanded into the side branch, into the LAD, then facilitating for us a recross with a further wire. And so we can do that with really the reassurance that we're not going to be going under a strut.
Yes.
And secondarily, we're not going to be kind of deforming or foreshortening the stent that was until this point under deployed in the left main stem. So here we have recross, and again you see very nicely that curling of the wire and passing on a loop, and then again passage of a balloon without really any great resistance into the side branch. And so from then that point we can undertake the kiss, which is absolutely mandated in this setting, and as we've already alluded to, the idea of using non-compliant balloons here, so we can see a sequential high pressure inflation, so high pressure into the LAD with a non-compliant 3.5, high pressure into the Circumflex with a 4.0 balloon, and then a nominal pressure kiss into the bifurcation, with the hope that we're bringing the carina into the midline,
the center,
but we're creating an ideal geometry of the bifurcation. And so here we have the angiographic result.
Maciej again looks angiographically beautiful. Would you accept this, or?
Yeah, with technique presented by Tom, I would definitely accept. But we all know that angiography may be misleading. For the average operator, I would recommend using any intravascular imaging. We have IVUS on a table, so it would be, I think, a mistake. Why? Because what we cannot see on the image, and this is particularly important for the left main, we can have, for example, stent deformation with the guiding catheter, and you will never see it on angiography. You can have still some malapposition of the stent, and of course, we know, although I think that here it's not the case, but we know the minimal luminal area which we'll have to obtain to ensure a good long-term result. So you should be at least 8 millimeters square in the left main, 7 at the bifurcation in the polygon of confluence, 6 in the proximal LAD, and if you stented 5 in the circ, I'm pretty sure those MLIs the requirements are fulfilled here, but definitely I would recommend to use IVUS in this situation.
Okay. Yeah, show us the IVUS.
So this is accelerated pullback, just so that you don't fall asleep, but LAD on the left, Circumflex on the right. And being critical, there is probably some residual stenosis at the ostium of the LAD, at the ostium of the...
So our participants were right.
Yeah, and the question then comes, should I have taken a 2 millimeter burr? I only took the 1.5 burr into the LAD, and maybe if we want the perfect result, then we have to take an additional step. And that was mainly through just time constraint. The other aspect about ensuring we don't deform the stent, we can see, I'm sure some will be commenting on the fact that the stent extends back into the aorta. it's a very, very partial extension back into the aorta with some malapposition at the very top end. And clearly, a further pot here would be a very reasonable thing to consider. We haven't got that captured, but that's an important thing to consider.
Maciej?
Yeah, I might just comment the issue of upsizing of the burr. I wouldn't do this here because we increase the risk of complication with big burr. What we want to do currently with rotational atherectomy, we just want to break the calcium to be able to deploy the stent. And having a 2.20 burr in this LAD with the occlusion of the circ up front, we may put the patient at the unnecessary risk. So I wouldn't do this. So I think your decision was absolutely right. 1.5 burr will do the job.
Yeah. The role of cutting balloon and argiosculpt probably after rota.
So that may be considered overkill. It's just really to be absolutely sure that we have optimized as much as we can, that we see expansion. The last thing you want is to is to deploy your stent and then find that you've still got quite a significant residual stenosis. So the taking of a non-compliant balloon at that point was important. I just happened to use a scoring balloon in addition to further maximize the preparation.
Yeah. Do you recommend always repot? So after this imaging, do you think that spheral deformation is relevant?
Always, no.
Yes.
I think we can see that there is a benefit of doing that in this case. So the concept being that having undertaken the KISS, that you may have an elliptical deformation of the proximal vessel. And so the idea being that by then repotting, you're generating a circular main proximal vessel again, which has been shown very nicely on the bench. There's not clinical data to support it, but conceptually it seems like a nice idea.
Yeah, and in this case, the left main is very short vessel, so this longitudinality, the ovality will be not, it will not influence the outcome of the patient.
Again, one question on the position of two stents. Should both stents have the same starting point as in culotte? You said no, you have minimal protrusion with the side branch. You try to minimize the length of the overlap. 3 layers.
And the same holds for culotte. Yeah?
And the same, now mini culotte is recommended, starting with short protrusion, and then with second stent you go cover to the ostium. And another question is, these are final images. You are the first author of the ESC consensus on imaging use, second part of the consensus. So question for you, is IVUS pre and post a must for all types of left main stenting?
So my personal, a must, I think no. We have to be realistic, and there are going to be cost implications, and there are going to be times when the patient is too unstable. Does IVUS assist in left main intervention? Absolutely yes. And we see here that taking it from the beginning to the very end of the procedure, it's influenced every single decision, and I think it's probably made for a safer and more effective procedure. Every case, no. We have to be realistic.
Yeah, we also published as a Bifurcation Club joint project with Gary Mims this year about the use of IVUS specifically for the left main. I think we are completely aligned. The same group of people wrote both articles, and we really strongly recommend it. But we recommend it in case you know how to interpret and use the values. Just saying I use IVUS is not enough. You need to change, you need to select adequately bigger balloons, better oppose your struts. That's the purpose of using imaging, not just I used IVUS. You really need to gain a couple of square millimeters inside the stent and make sure that it's really optimally deployed.
Just
you agree?
2 words, talking about this paper, you can find very nice results of meta-analysis showing that even for the mortality, you can find the advantage of IVUS if you pull together the result of the trial. One of the limitations of IVUS is that you cannot judge, you cannot assess the side branch with an IVUS probe having in a main vessel. So this you cannot say that, okay, circumflex is widely opened if you don't go into the circumflex and make a pullback from the circ. Yeah? So if you have a pullback LAD, left main, take 1 minute more and do the pullback from the circ to the left main, because this is the only way to assess really the expansion and the ostium of the side branch.
Yeah, we already answered this, but there is a paper that describes novel technique to treat rota, 2 vessels in bifurcation without removing workhorse wire by using guide liner. What do you think about that?
So you've already touched upon that. Yeah. Clearly, the use of the guide liner is going to reduce the size of the burr. So in this instance, we wouldn't have been able to use a 2.0 burr. But absolutely, it can be done. I haven't done it, so that's hence saying no. But I think it's reasonable.
Maybe one more comment. You should not be afraid of losing a side branch with a rota, a single wire, because what you do actually, you break the calcium, and if you take a bigger burr, you debulk the plaque. Yeah, so you remove the plaque from the so it's really very rare when we're losing your side branch after rotation atherectomy of the main vessel.
Yeah.
In our cath lab, we don't have IVUS because of financial constraints. We have rotablator. Can we perform this case? I saw during EuroPCR live demo of left main PCI with calcified lesion without the use of IVUS.
Yeah, of course you can. The benefit of the IVUS is just giving you more information, but you can see the calcium on the angiogram. So with a poorly inflating balloon, soft palpation, then to move up to using rota to debulk is very reasonable.
Is there any role of dedicated stents like exposition or Triton in this kind of anatomy?
I wouldn't think about exposition, of course, for this particular lesion because of the radial strength and this bulk of calcium. As for Triton, what I would like to have is a Triton-like stent with drag on it. And then I would use it because this is nothing else like just reverse culotte technique, simplified culotte technique. But we all know that even the current recommendation in the European Society of Cardiology, there is no more bare metal stents on our shelf. So unless we have a dedicated drug-eluting stent, we have to do.
The last question is what kind of pharmacotherapy during the procedure would you consider to be 3A?
Although the patient presented with the occlusive circumflex, in fact, it reopened, recanalized very promptly. We just used unfractionated heparin with ACT guidance. Okay,
thanks. So I think case was excellent. Congratulations. It was really fantastic demonstration. There are several key messages I would like to share. So 2 stents should be considered in complex through bifurcations. It's important to plan procedure, and lesion preparation is also very important for stent expansion. Be ready to change your strategy and adapt. Pot and final kissing are essential if you use complex 2-stent strategy, and image guidance aids decision making and optimizes outcomes. So we have reached the end of this PCR webinar on step-by-step planning and performing 2-stent upfront strategy for bifurcations, and we hope you found it useful. Our next webinar on bifurcation will be live from Toulouse with Jean Fajadet and Thierry Lefebvre and Jacek Legutko on November 15. And on behalf of my colleagues, I would like to thank PCR team for support in preparing webinar and to thank Medtronic for supporting this independent series of educational programs on left main disease. All the best from all 3 of us. Thank you very much.
Thanks, Goran.